There we go. All right, great. So welcome to the presentation. We're going to be talking about hypothyroidism. And I'm going to be speaking for about 30 to 40 minutes, and then we'll have some time for Q&A. That's my intention. Sometimes it goes longer, sometimes shorter. We'll see how it goes. And if you have any questions as we go, please put them in the chat. And hopefully I'll be able to scroll through that after we sort of finish the initial part of it, and we can address those questions, whatever they are. For those of you who have been with me for previous presentations, I usually try to share way too much information, and it's sort of like overwhelming. So I'm trying to rein that in, because sometimes when you reach for a lot, you don't get anything. So I'm going to share some very succinct things about hypothyroidism and why it happens and why it is that so many people continue to suffer from it and have it not be recognized or properly treated by their doctors. And it's, the same story on another flavor, right? Of a lot of what happens with chronic syndromes and chronic pain, which I see a lot of. And the overall principle is that conventional medicine, while we do really great things for acute care, and we're really good at simple problems, when it comes to chronic, multifactorial, complex problems, where it's harder to collect good data and harder to have really hard science, a lot of doctors just say, look, I'm not going there. And they don't want to think about it. They want to think about the simple problems. And it's complicated. So anyhow, let's jump into it. I'm going to share some slides. Can everyone see those slides? I'm seeing Racheli. Can you actually see those slides? Great. And so just as a way of introduction, I work with Rose Wellness. It's a company that's in America, and they're based in Virginia, but they provide telemedicine and in-person integrative and functional medicine consultations. And so I work with them doing telemedicine and see people in a variety of different places where I practice in the US. I'm personally based in near Jerusalem, Israel, and I see people here. But the people who are in America, I see through Rose Wellness. So just to kind of clarify that, if anybody's wondering as we go along. And so let's jump into it and let's see what we can learn together. Great. Okay. So what is a thyroid? Let's start off with that. Basics first, right? So this is a person's throat, and the thyroid is right here, like at the base of the throat below, wraps around basically in the front of the larynx and the trachea. And it's shaped like a little butterfly, and it's about the size of a walnut. And it's about 20 to 60 grams, which is like 1 or 2 ounces. And the hormones from the thyroid affect all the cells of your body. And their basic function is they are the set point of your metabolism, your cellular activity. So all of the cells of your body have a certain baseline level of awakefulness and activity, and how much are they buzzing and ready to do stuff. And the thyroid turns that up or turns it down. It's like a gas pedal of the body, or the idle, like there's something in an engine. This is more old time cars, but like an engine has an idle, and the idle is how fast is the engine running at baseline before you hit the gas. And if the idle's on too high, the engine's like too revved up and it burns up the gas and hurts the engine. If the idle's too low, the engine stalls and chokes and coughs and doesn't operate properly. So that's what the thyroid basically does for all the cells in the body. And that's why it affects so many different things. And so thyroid hormones come out of that gland, and they go to all these different parts of your body. Your brain, they affect body weight, they affect brain development, as well as brain function and mood and neurologic functioning, body temperature, bone health, muscle contractions, the way your liver works and detoxifies your body, the way your liver produces substances that helps your gut be healthy. It affects hormones in your menstrual cycle. It can affect fertility. The metabolism of glucose is a really big thing that's affected by thyroid. In the liver, I didn't mention it's involved in kind of adjusting how the body absorbs fats. And so, for instance, people with low thyroid can have high cholesterol. It affects breathing rate, heart rate, and so on. So it's really a master gland, manifesting in everything. And thyroid is there's a lot of different thyroid diseases, and the American Thyroid Association says, like, up more than 12% of the US population at some point will develop some kind of thyroid disease. And something like 20 million Americans have some sort of thyroid disease. And many of them are not aware. And women, for reasons we don't understand, are 5 to 8 times more likely than men to have thyroid disease. And there's serious illness that you can get when you have persistent hyperthyroid or hypothyroid. And so the main classes are either hypothyroid, where the idle of the engine is turned down, or hyperthyroid, where it's going too fast. And then there's also thyroid cancer and tumors and things like that. And there can be various reasons for hypothyroidism or hyperthyroidism, nutritional reasons, autoimmunity, various kinds of things that can affect it. But these are the general classes. I want to call attention to something called Hashimoto's disease. Has anyone heard of that before? And so Hashimoto's is autoimmune thyroid disease that is the most common reason for hypothyroidism. Some people with Hashimoto's actually have hyperthyroidism at first. What happens with Hashimoto's is the body develops antibodies against the thyroid tissue. And so in the early stages, those antibodies can stimulate the thyroid, and actually when they knock off thyroid cells, little pockets of thyroid hormone get released into the blood. And so a person can be hyperthyroid at first, and then it often sort of stops being hyperthyroid and becomes hypothyroid, because those same antibodies affect the function of the high thyroid hormones, like we'll talk about. And that's really one of the main controversies. It's like there are so many people who have Hashimoto's disease who the regular doctor treats them according to the typical protocol, but it doesn't really help with their symptoms, or it helps a little bit, but they're still suffering. They're still tired. They still have brain fog. They still have various symptoms that are hypothyroid system, even though their numbers are right. And so we're going to talk about why that is, why it is that someone can have their thyroid medicine optimized according to the best of conventional medicine, but still be suffering. All right. So I'm just going to read the questions that come in, and I'm going to either talk about them now or later. Let's see. Is there any relation genetically between both hypothyroid and hyperthyroidism? My mother has Hashimoto's, but I've been experiencing hyperthyroid symptoms. So that's a really great question. And like I said, maybe I hadn't spoken about this when you wrote that note, Katie, but that a person who has early Hashimoto's could have hyperthyroid symptoms because they can be stimulating. So hypothyroidism, we're going to focus on that today. The cellular metabolism is too slow. Overall, it's kind of a sluggish, tired, weak, slow, brain fog kind of thing, but it doesn't just affect your brain and your energy levels. It affects all your organ systems. And here, I think, yep, some of the symptoms of hypothyroidism: tiredness, fibromyalgia, being sensitive to cold, menstrual cycle irregularity, weight gain. It's like we all think about weight as, okay, if I have too many calories and I'm not active enough physically, I can gain weight. And that's a lot of it. But there's also this issue of inflammation that goes on in weight gain. And all of that's connected to hypothyroidism. It's a vicious cycle. Cardiovascular disease, people can actually get really bad heart disease from being hypothyroid, both in terms of narrowing in the arteries, as well as cardiomyopathy, where the muscles kind of get weak in the heart, constipation, depression, brain fog, loss of sex drive, neuropathy, peripheral neuropathy, carpal tunnel syndrome, which is kind of a specific kind of neuropathy, slow thinking, muscle aches and weakness and cramps, dry, scaly skin. There's a lot of different symptoms. And the important thing is that, like, thyroid symptoms are what we call non-specific. And so hypothyroidism gets called like the great imitator, because it seems like so many different other things. And, to give credit where it's due, for a lot of doctors, it's hard to deal with hypothyroidism because the symptoms are so non-specific, and the symptoms could be because of so many different things. And then they have this guideline from the whatever endocrine society that says if the TSH is in this boundary, then don't worry about the hot thyroid. So that's how a lot of doctors practice, unfortunately. And it's not good for patients. But I sort of understand where it comes from, because it can be so overwhelming. And a lot of doctors don't have time to think it through. Somebody comes in with 12 of these symptoms, like, what do they do? Oh my gosh. Like, let me rule out thyroid disease. So the TSH is normal. Great. It's not that. Unfortunately, and maybe some of you have had this experience, I've seen hundreds of people who have come to me who have some number of these symptoms who said, oh, my doctor said my thyroid's normal and they gave me an antidepressant. And it's like insulting and it's humiliating. A lot of people get really humiliated and shamed by their doctors for having these things and for the doctor not having the time, intention, education, sensibility, or who knows what to actually figure it out. So they kind of blame the patient and say, what's wrong with you? You're depressed. Take this antidepressant. It's very annoying. I mean, I see a lot of people who, yeah, Jackie's acknowledging exactly what happened to me. For sure. And it's really so unfortunate because a lot of times there's really a biological thing going on and we need to discover what it is and treat it. So what are the thyroid hormones? There's three main ones that I'm going to speak about. Katie's saying yes, exactly, about that whole bad trip that we get with conventional doctors sometimes. So T3, and it's called T3 because there's three iodines, right? And T4, there's four iodines. That's iodothyronine, sorry. And then thyroxine, which is T4. And T4 is the storage form. It's the main thing that the thyroid generates and produces. And then it's meant to get converted into T3. And T3 is the thing that actually works on your cells. The T3 level is what matters. We're going to talk about the whole loop of regulation of the thyroid and how the body maintains T3 levels and T4 levels. But so T4 is storage. And then what happens is one of those iodines gets broken off. And then that one, T3, is the one that activates your cells. And there's these enzymes called deiodinases, which basically means it pulls an iodine off. The other thing that can happen is that T4 doesn't always get converted to T3. It can get converted to something called reverse T3. Reverse T3, there it is. Look at that, RT3. It's like a mirror image of T3, and it's not active. So if you were to put them all in a bucket, it would look like T3 and RT3 are the same thing, but it's not active in the cells. And it's meant to exist as kind of a balancer. It's a way that your body can kind of adjust how much active thyroid hormones produced, right? So your thyroid gland's producing T4, how much becomes active versus inactive. And one example of where this is useful is like hibernation, right? When a bear hibernates in the winter, the reverse T3 goes up. The body converts, and because the bear doesn't need to be active running around doing stuff, it's sleeping most of the time. So it turns down the metabolism by shunting. Instead of making T3, which is active, it makes reverse T3, which is inactive. And one of the big problems with why people suffer from hyperthyroidism is because their body, for a bunch of reasons, produces more reverse T3 than T3, that reverse T3 than T3, so they've got an inactive thing. And so stress, starvation, inflammation, and a lot of chronic illnesses or toxicities can increase the conversion of T4 to reverse T3. And that's when people can be hypothyroid with a normal TSH. So we'll talk about that. So Bela's asking, what test do you recommend besides the regular test that's done and says it's okay? Yeah, I'm going to talk about that. Great question. So I sort of spoke about this in words, but here's a picture. Here's your little butterfly-shaped thyroid gland. I should maybe color that in next time. It's producing T4, and the T4 can be converted to T3 or reverse T3, and they both go on to the receptor on the cell, but the reverse T3 blocks the receptor. And the T3 goes and activates the receptor, and then it tells the nucleus, the brain of the cell, to be active. So that's the key physiologic step here. And so this is kind of the overall loop that's regulating the thyroid. Let me explain what's going on. Here's a picture of the brain. And right here in the middle of the brain, you have these sort of master glands called the hypothalamus and the pituitary gland. I'm sure everyone's heard of the pituitary gland. So the pituitary gland produces this thing called TSH. Look at this green arrow. That's thyroid stimulating hormone. And that's what stimulates the thyroid gland to produce the thyroid hormones. That signal comes from the hypothalamus that has something called TRH, which is thyrotropin releasing hormone. Thyrotropin is TSH. It's the thing that makes the thyroid act, right? That's why it's thyrotropin. And then when the body produces thyroid hormones, not only do they go into your cells and activate your cells, but they have feedback to the pituitary and the hypothalamus that says, hey, we got enough thyroid hormone down here, slow down the TSH. And that's what keeps it kind of regulated. It's meant to be like the thermostat in your house, except a lot more sophisticated, so that when your house gets the right temperature, the thermostat says, okay, it's whatever number of degrees you set it at, depending on what country and whatever else, turn off the heat. And it's like so many things. It's a feedback system. And so most doctors check the TSH and maybe the T4. And if you think about it, it's a little weird because the T3 is the one that's so active in your cells. But it was figured out with lots of research that for most people, the TSH is a thing that's more stable and more measurable. And for whatever reason, the endocrinologic powers that be decided, look, check a TSH, maybe check a T4. And there's three main categories that they think about in conventional medicine, which is normal, where your TSH is 0.4 to 4.0. And that's considered normal. And then this thing called subclinical hypothyroidism. It's like a big controversial thing. What do we do about it? Where your TSH isn't normal, but it's below 10. And they say that's subclinical hypothyroidism. So if your TSH is 6, your doctor might not want to treat you with thyroid hormone. They might just say, let's watch that. Or they might treat you. But the ironic thing is this, is like in the European thyroid agencies, they consider 2.5 to be the cutoff. And that's the way it was in America for a long time. And it's sort of a weird thing about lab values, right? Because the way these things are decided is what's the average in the population. And so this is sort of a crazy thing, right? But if a population is getting sicker and their values are changing over time, then over time, if they keep measuring it, they're going to change the normal range. Because here's what's average. And if a whole lot of people have subclinical hypothyroidism or a hypothyroid because of reason I'm about to talk about, but their TSH is normal, so to speak, they're going to consider them normal and consider that TSH of whatever, and they're going to open up those values. And I think that's what happened maybe a dozen years ago or so when they decided up to 4 is normal. And so, you know, this next part is that a lot of doctors aren't really thinking about the symptoms, they're thinking about the numbers. And I see this happening in a lot of different aspects of healthcare, right? Like I take care of a lot of people with chronic pain. And so sometimes a person, well, they've got a normal MRI, they've got a normal CAT scan or whatever it is. So there's nothing wrong with them, which is often completely ridiculous because there's so many things that can cause pain that don't show up on the MRI. And the issue is a lot of docs are not doing a clear clinical exam. They're not doing a clear history where they really pay attention and they ask, okay, when did your symptoms come on? What was going on? What was triggering it? What was the history before that? What else is going on? Let me understand the pattern of the complexity that might be making this all happen. And there's actually a physical exam finding that a lot of doctors don't do anymore. When I check the reflexes, right? Like a normal reflex, boom, right? It goes whoosh. When someone has hypothyroidism, you check the reflex and it's called a reflex lag. It's like boom, ooh. Instead of boom, it goes boom, ooh. It's like a slow recovery. Boom is normal. And then hypothyroid is like boom. So that's a hypothyroid reflex. And so when I see that with a normal TSH, I'm like, wait a second. This person has hypothyroid symptoms. They've got a reflex lag on the exam. They've got chronic pain. They can't get out of bed in the morning. Their cholesterol just went up. They can't lose weight. Okay, maybe there's something else going on with the thyroid. What do we do? So let's talk about why this happens. This is like the core information of why it is that people can have dysregulated hypothyroidism with a normal TSH. And I never learned about any of this stuff. Like I did an internal medicine residency. I passed my boards. I didn't know any of this stuff. It wasn't until like 10 years ago when I started studying functional medicine and looking at all this research and going to conferences. And I was like, oh my gosh, this explains so much, right? So this is the same picture we looked at before. And these are the factors that help the body produce T4. And there's nutrients like iron, iodine, tyrosine, which is an amino acid, zinc, selenium, vitamin E, a number of B vitamins, vitamin C, vitamin D. These are essential to production of thyroid hormone. And then we've got all the, wait, and then here are the factors. Let's talk normal first, right? So this is what we need to make thyroid hormone. And then here are the things that help the conversion of T4 to T3. The main things are selenium and zinc. Those are two minerals that are frequently deficient in many people. More people have enough zinc now after COVID because they started taking zinc, which is great. Probably helps thyroid. But that's that crucial step of making it T3 instead of reverse T3. And now here's the first piece of pathology, right? Because like, here are the things that make the body produce more reverse T3 and less T3, and that's the inactive one that blocks the thyroid function. So stress, trauma, starvation, like we talked about, inflammation, when there's increased inflammatory chemicals in the body, various toxins, heavy metals, certain organic pollutants, infections, liver and kidney problems, and a bunch of different medications. They favor the production of reverse T3. And so let's get back to let me just go back to this, right? What? I went the wrong way. Sorry about that, folks. Right, here we are. So the body's producing a lot of reverse T3, but your brain can perceive that reverse T3 as T3. And the other thing that can go on is, I'll get into this some more. The point is that your body's producing inactive hormone because of all these changes. Your doctor's not measuring your reverse T3. They're just looking at your T4 and your T3, and it could still be in normal range, but you could have a bunch of reverse T3 blocking it. So this process of creating T4 and T3 might keep going on, but if the body's also increasing a bunch of reverse T3 because of a low-grade inflammatory problem, because you got chronic liver, fatty liver, because you have chronic dysbiosis or something else that's creating an inflammatory picture, metal toxicity, other things, a lot of stress, previous trauma, then your body's producing too much reverse T3 and it's blocking your thyroid hormone from working. So your numbers could look normal. Your TSH might be creeping up. It might not be, for reasons we'll talk about in a bit. And then here are some of the things that can inhibit proper production of thyroid hormones. Sandy's asking, is there a test for reverse T3? Yes. Which medication reverses T3? I'm not sure I understand the question, Bela. Do you mean reverses reverse T3 or causes reverse T3? Okay, that's what you mean. Which medications cause increased reverse T3? I'm going to get there. I hope I'm going to get there. So factors that inhibit proper production of thyroid hormones: stress, infection, trauma. There are a lot of the same ones here. But again, toxins, pesticides, mercury, lead, cadmium. Like, what's the toxins in cigarettes? Cadmium, among other things. Also arsenic. Celiac disease is known to be a big inhibitor of thyroid function. And then here are things that actually help the body be more sensitive to thyroid hormone: vitamin A, exercise, zinc. And so, yeah. All right, let's go forward. It's a lot of information. I think the take-home message, the main thing is, there's a bunch of stuff that can prevent your body from producing thyroid hormones. There's stuff that can cause your body to produce more reverse T3 that blocks hormone function. So they're all important to look into. And so relying on only TSH and T4 misses the diagnosis in many people. And it's not everybody. There are a lot of people who get diagnosed with hypothyroidism and they get their thyroxine, which is T4, and it works for them. And some of them, it works for them for 5 years, 10 years, 20 years. And then for some people, it actually stops working. And you wonder what's going on. There are some people who they have to keep increasing their dose of thyroxine. And a lot of docs aren't really thinking about it. They're just like, oh, okay, well, you're getting older. We have to increase it. They're not thinking about why. And here we've got all these reasons potentially why. So would retin-A cream increase sensitivity? Meaning increase, you're asking because it's a vitamin A derivative, Lynn? That might be the reason where the question is coming from. It's a good question. Retin-A is complex. And so I don't know if it increases sensitivity to thyroid hormone. I actually haven't prescribed Retin-A in a long time. My knowledge of it is something we use for acne. We put it on the skin. It's topical. It's not really supposed to get absorbed systemically. So I don't know. That's just me thinking out loud. So we've already sort of discussed it a little bit. The problem with relying on the TSH only, which is what a lot of conventional doctors do. It's kind of like if you put your heater right under the thermostat in your house. You got a thermostat on the wall, you set it to 70 degrees or whatever it is, and you take a little portable heater and you put it under there. That's also turned on in addition to the system heater, right? And so the thermostat's getting heated. So it heats up and it gets warm and it says, oh, we're warm enough. And it turns off the heat. Meanwhile, the rest of the house is cold. And so it's not a perfect analogy, but the whole idea is that the pituitary can get confused. Many things affect the conversion to T3 and the sensitivity to T3. And the pituitary gland has been shown that it can have different sensitivity to T3 than the tissues. And it's also been shown that the level of T3 in the blood can be different than the level of T3 that actually gets into the tissues. So you've got a few different places in this loop, this feedback loop, where what you get in the tissues is different than what the pituitary and the hypothalamus are seeing. And those are the control centers that are determining how much TSH to produce. So that's why in certain people where their systems or their tissues are less sensitive to T3, they become hypothyroid, but their pituitary gland doesn't, quote, see it. So it doesn't increase the TSH. So they have a normal TSH and they're not getting enough T3. I hope that makes sense for people. So this is from a paper from 2017 called the Journal of Endocrinologic Investigation. And it's called an expert consensus report. And here's what they wrote. I'm just going to quote what they wrote. And it's kind of what I just said, but I just want you to know I'm not making this up. This is a peer-reviewed journal. A lack of correlation between TSH and peripheral tissue levels of T3 gets worse in conditions like lots of physical or emotional stress, chronic illness, diabetes, insulin resistance, obesity. Leptin resistance is an aspect of obesity, depression, chronic fatigue, fibromyalgia, PMS, weight gain, and weight loss, and dieting. And in these conditions, the tissue levels of T3 can drop out of proportion to the serum T3. And so they quantify that. They say, while serum T3 levels may decline by 30%, it's significant, but it might still be in the normal range. Meanwhile, tissue T3 may decline by 70 to 80%. I just want to clarify, tissue T3 is like what's in your cells, what goes into your organs, your muscles, your brain, your heart, the places where the T3 is meant to kind of control your metabolism. So it's not getting in there. So what happens is you get cellular hypothyroidism where the cells don't get enough thyroid hormone activity, but there's a normal TSH and T4 and T3. So now they've written it free T4 and free T3. It's another aspect, another controversy, right? Because there are proteins that are called steroid binding proteins and thyroglobulin binding proteins. They carry the protein around the blood. They're sort of the storage in the blood of the hormone. And the hormone that actually works is the free hormone. And it's like an equilibrium. There's a certain amount that's free, and a lot of it's bound to that actual protein. And so when you measure the total T4, like most docs do, or the total T3, you're not looking at the free active one. And that's another place where functional docs think a little differently. My view is, okay, let's measure the active hormone as opposed to the bound hormone, because a lot of different things can affect the amount of protein that's binding the hormone, and also how tightly the protein is grabbing onto that hormone. And so, for instance, if there's a higher amount of protein, if there's a decreased amount of protein, if there's a higher amount of protein and a lower amount of binding, then basically what's going to happen is your total T4 or T3 might be normal, But meanwhile, your free T3 could be much lower in your blood. Their conclusion as a result is that TSH can be a poor indicator of peripheral thyroid levels in the presence of such conditions. They go on to say, however, TSH is a good measure of overall thyroid control in up to 80% of the people. 80%, that means 20% of the people it's not. So I don't know, to me, that's not very good numbers. And to me, that means that when someone comes into my office and they got hypothyroid symptoms, then you can't touch the TSH. You can't trust it. And it might be fine for screening, because that's another place that things get mixed up. You know, it's like a screening test is, okay, the person's 50 years old. We check a TSH. It's normal. We're not going to worry about it. They're not complaining of any symptoms. They find some people with hypothyroidism that way. Some people get diagnosed because they just routinely, as part of a screening exam, got a TSH and it was high, and then their doctor is able to diagnose what's going on. But for a person who has symptoms already, the doctor should be more suspicious that there's a problem with the thyroid, and they should look more carefully than just looking at the TSH. That's my take home for this. Okay. Oh, yeah, right. This is their last comment. Their last comment, we already talked about this. So what's the integrated approach to optimizing thyroid function? There's awareness, there's diagnosis, there's treatment. Awareness means being aware of all the different things that can affect thyroid function, like I showed in that picture. Being aware of all of those subtle nutritional and lifestyle things that can throw off the regulation of the thyroid and still have a normal TSH. If you're not aware of it, you're not going to look for it, right? And then diagnosing it, we think and we measure more carefully. And then treating it, it's a whole different ball of wax, because we try to treat the underlying issues. The way I like to say it is we go upstream towards the root cause of the disease, right? Upstream, downstream. Upstream is where things start. Downstream is over time, how they show up. The other metaphor is like the roots of a tree. The roots of the tree are the foundation, the genetics, the early life experiences. That's what happened to you when you were, before you were born, when you were in the room, 1 year old, 2 years old, infections, exposure, antibiotic, trauma, stress, all different sorts of things that can shift the set point of your body. And then the trunk of the tree and the branches of the tree are the triggers, the things that could have happened that triggered it, that really bad injury, the trauma, the infection, getting like a horrible gastrointestinal infection and getting IV antibiotics, all these different things that can go on that can trigger changes in your overall biological functioning of your body. And then from there, you get out to the leaves and the small branches, and that's where we define disease and we diagnose disease. So all this stuff is going on, and conventional medicine is just looking at the leaves. That's where all the ologists work. The rheumatologist and the gastroenterologist and the whatever. All of the specialists are looking at the leaves. They're looking at end organ damage. They're not looking at the roots, the underlying drivers of the disease process. So let's keep going here. So I aim to do broader testing of people who have hypothyroid symptoms. And that means when someone's got hypothyroid symptoms, looking at a TSH and a free T4 and a free T3 and a reverse T3. And in certain conditions, getting those thyroid antibodies. There's something called a TPO antibody and a TG antibody. And those are the things that are elevated in Hashimoto's. They're important not just because they can impair the thyroid function, because they're also clues that the person has an autoimmune disease. And if a person has an autoimmune disease, if they've got an elevation in their systemic inflammation, it can frequently be affecting more than just the thyroid gland. So one example of that is gluten sensitivity. There's a big association between celiac disease and Hashimoto's disease, because there's what we call molecular mimicry. The antibodies against gluten look like, so to speak, the antibodies or the proteins of gluten look like the proteins in the thyroid. And so the antibodies that get produced against gluten can mistake the thyroid and actually attack the thyroid or generate the anti-thyroid antibodies. And what we're discovering is that gluten's not just about the gut and the thyroid. There's other organs that can be affected too. For many years, we thought, okay, gluten is celiac disease. And so they have these tests for gluten sensitivity, which are really about the proteins and the antibodies that are relevant to celiac disease. If you go to a doctor and you get a celiac test, they look for antibodies against gluten that attack the gut, that were relevant to celiac disease, but they're not looking for the antibodies against gluten that attack your brain, that attack your thyroid, that attack other parts in the body that can actually have bad outcomes from gluten sensitivity. So Bayla's asking, great question, which medications affect conversion of T4 to T3 and what autoimmune diseases affect it besides celiac? Great question. So I'm going to have a little slide, I think, that talks about some of the medications. So hold on for that. Basically, I'm going to show you another slide about why inflammation affects thyroid function. Any autoimmune disease, and even any chronic inflammatory disease that's not autoimmune, can impair thyroid hormone production. It impairs the conversion of T4 to T3. It can also increase the conversion of reverse T3. And so let's just clarify what that means, right? Some people have low-grade inflammation that's not autoimmunity. Their immune system is ramped up. They have increased inflammatory chemicals in their body or a change in the inflammatory chemicals of the body, but they don't have antibodies against their own tissue. Those are two overlapping but potentially different phenomena. And so in both cases, there's increased inflammation. In autoimmune diseases, there's increased inflammation plus antibodies against particular things in the body. So things like multiple sclerosis or Hashimoto's disease or autoimmune kidney disease or autoimmune lung disease or lupus or other things where there are antibodies that are attacking the body itself are like a subset of overall inflammatory disorders. And it's really only been in the past 20 or 30 years that we've been really starting to recognize this phenomenon of low-grade inflammation that isn't an autoimmune disease and doesn't even necessarily show up on the standard tests that doctors do. You know, the standard test that most doctors do is a CRP, a C-reactive protein, sometimes an erythrocyte sedimentation rate. But those are not positive in everybody who's got increased inflammation. And that's been borne out by a lot of studies that are looking at these subtle chemicals called cytokines that can be elevated that are pro-inflammatory. You may have heard the names of some of these things like interleukin-6 or tumor necrosis factor. And these are things that drive inflammation that are involved in all sorts of inflammatory illnesses. And that's almost all chronic illnesses. So I'm getting distracted. This stuff is just cool and important to know. So the integrative approach, we do broader testing. We consider the things that alter thyroid regulation, some of whom we spoke about, like inflammation, like nutritional deficiencies, toxicity, whether it be heavy metals or fertilizers or certain what we call organic pollutants, gluten sensitivity, stress and stress hormones. And so stress itself can affect thyroid, and then cortisol, which is one of the stress hormones, affects thyroid function. And then there's medications like we talked about. People are asking great questions. So Bayla is saying fibromyalgia seems to be inflammation of nerves and brain. So can it affect it? I'm presuming you're wondering, can fibromyalgia affect the thyroid? If that's your question, Bayla, what I would say is more accurate to say is that there are underlying drivers of inflammation, and that can result in various end organ effects. And so it's like that tree metaphor. There's the roots, the trunk, and the branches of the tree. If the immune system's overactive, it can show up as fibromyalgia with kind of a low-grade inflammation in the brain, what they say glial activation, which are these inflammatory immune cells in the brain that get activated and increase hypersensitivity. They can contribute to brain fog and anxiety and all sorts of other stuff. And then you also can get fibromyalgia. You can also get autoimmune thyroid disease. So it's not that the fibromyalgia causes thyroid disease, or that the thyroid disease, well, let me say it differently. It's not that the antibodies to the thyroid are causing the fibromyalgia, or that the fibromyalgia is causing the Hashimoto's. It's that they're both being driven by the same thing. On the other hand, someone who just has hypothyroidism, whether it's from Hashimoto's or just nutritional, or because, 20 years ago they had some sort of surgery because they had to take out their thyroid gland, they can develop symptoms of fibromyalgia, because that's part of what can come up with hypothyroidism is widespread pain, brain fog, stomach stuff, skin stuff, all the different things that people with fibromyalgia can experience. So the integrative approach, we think about these things and we treat them. I'm not sure what happened to this slide. It used to say, treat them. We want to correct the things that can be driving thyroid dysregulation. So just taking a step back here and talking about Hashimoto's, and I've sort of touched on this, but this is kind of a cartoon of the brain. This is a cartoon of the gut. This is a cartoon of the immune system. And research in recent decades has shown that, there is this brain-gut immune interaction where they're all affecting each other. They're so intimately connected. It's one system. We think this is your brain because we can do an autopsy and say, oh, there's your brain. And we think this is your gut because of the same reason. But the fact is that your brain and gut are communicating constantly in both directions, so much that we can't really say where one ends and one begins. We can say anatomically where one ends and one begins. This is my brain. This is my gut. But functionally, the amount of communication is so profound that it's hard to separate them. And the same thing is true of the immune system. I remember hearing about this kind of thing when I was first finished residency and I first started working in medicine. And I was very academic in my practice and hadn't learned all this stuff. And I remember my friends and colleagues and we'd hear about this idea of leaky gut syndrome. Has anyone heard of that? Some have, some haven't. Leaky gut is the thing that goes on in your gut. There's a number of different changes. You have changes in your biome, which are the trillions of bacteria that live in your gut. And you get this very subtle breakdown in the barrier of your gut. Your gut is a tube. Your whole intestinal tract is a tube from your mouth out the bottom, right? And that tube has a very specific border or boundary that has very specific cells that are meant to make a barrier so you just absorb nutrients and water, and you don't absorb stuff that you shouldn't. And you don't absorb, for instance, little products of bacterial cell walls or undigested food that's floating around in there. Those things are meant to stay inside your gut until they're ready for absorption or until they're broken down. And your gut's surrounded by millions of immune cells. There's gut-associated lymphoid tissue. The surface area of your gut is like the size of a ping pong table. It's huge, and it's a big immune system. Your gut has one of the biggest immune systems in your body. And so that's why these things are so profoundly interconnected. When the gut gets out of whack and you get dysbiosis and leaky gut, whether you have inflammatory bowel disease or just irritable bowel disease or even no symptoms at all, you can get immune activation that affects the whole body. And we used to joke and laugh about leaky gut. Oh, that's such a bunch of nonsense, right? That's the way we thought about it back in whenever the heck it was. And now when you look at almost every specialty journal, every specialty, their journals are talking about the gut-brain immune axis and how it affects their diseases, their chronic diseases, whether it's internal medicine, diabetes medicine, gastroenterology, psychiatry. All of the ologists are talking about the gut-brain immune connection. It's amazing. Judith, it's best, can you type a question in if you have a question? Type it into the chat. I see your hand is raised. I'll come to you at the end if you haven't typed it into the chat. I just want to answer a couple of quick questions here. I think we spoke to your first questions, Bela. Maria G is asking, how do I know if I have gluten sensitivity? Great question. The way I think of it is this. If you get the gluten test for antibodies and they're positive, then yeah, you've got gluten sensitivity. The other best way, the gold standard, is that you eliminate gluten from your life for like a month. You just get really strict about it and don't eat any gluten. It's a process. You really have to think about it. You have to look for hidden sources of gluten. It's like you're sitting around a bonfire with your friends and you stop putting wood on, so the fire starts burning out. Then after 2 hours, somebody puts another log on there and the fire comes back up. So gluten's like that. You could stop eating it for a week and not really notice anything different. And then you have like a piece of pizza, but your fire comes back up. So you never really notice that it's making a difference. You got to give it 3 to 4 weeks of just strict withdrawal of gluten, and you see how you feel. And then you add it back in. So we call that an elimination diet with reintroduction. And when people have chronic syndromes like this, I usually recommend there's a few different things that I suggest that we stop for a month before we go back and reintroduce them to get a sense of, well, what's really bothering you? So hopefully that answers the question, at least in theory, Maria G. In practice, it's another story. And Bela's asking, so LDN affects the cytokines. So does it bring inflammation down and that affects the conversion? So LDN, for those of you who don't know, is called low-dose naltrexone. Naltrexone is a medication that blocks opioids, and it's in high doses used to help people with substance abuse resist their urges, and because they lose their desire. It makes the heroin or the alcohol not work as well. But when we give it in very low doses, what it does is, one of the things it does is it's anti-inflammatory. It reduces a certain inflammatory pathway. It's not a heavy-duty slam like those strong anti-inflammatory drugs or cortisol or prednisone. So it's more subtle, and it very gently tricks your body to increasing the amount of endorphins, and that brings inflammation down, and that can reduce the antibodies against the thyroid and Hashimoto's. So I prescribe it a lot for people with Hashimoto's, and also for fibromyalgia and fatigue and other chronic pain things and chronic inflammatory things. For some people, it works really well. And you're right, Bela, it reduces the inflammation down, that not only can reduce those autoantibodies, but can also sort of take the pressure off that whole thyroid hormone production system, which is impaired from inflammation. Yeah, so Racheli's asking, how would one get these tests? The doctors are declining the need to have them. It's really an unfortunate situation. So Racheli, I know that you live in a country where the system is very much old school and very much like population-based medicine. For them, 80% is enough. So there are some doctors who are willing to get them done and some that aren't. So in my practice, what I do is when I see someone where I suspect these things, I write a letter to their doctor and I say, here's why we should do it. And sometimes I have little references in the bottom. Here's why you should check these things, right? In Israel, where you live, they actually don't do a reverse T3. You can't get it done. It's crazy. I've called various labs. They won't do it. There are labs that can be sent out to everywhere. There are private labs everywhere. It's a bit of a process. You want to find the right practitioner. First thing is finding a fine primary care doctor who's open-minded, even if they don't really know all this complementary medicine stuff. Finding someone who's open-minded who will cooperate with someone who can recommend a broader approach to testing. Jackie's saying, yes. Bailey's saying, gluten, the effects of gluten, right, yes. Exorphins affecting LDN. I don't know what exorphins are. Bela, please tell me. I still wonder which tests show the RT3. Reverse T3 is a test itself. It is a blood test that can be done in a lab. And we measure it and we can look at the ratio of reverse T3 to T3. Let's keep going here because this is taking longer than expected, as always. What specialists can test and verify for hyperthyroidism? Robert, I want to make sure you mean hyper and not hypo. Either way, a really good internist or family practice doctor can do a lot of these tests if they're staying up to game and they're really taking their job seriously. And some don't go into it. And then they might refer you to an endocrinologist. And an endocrinologist is a specialist in all the hormones. So, all right, I think we already talked about this, that this is part of what drives Hashimoto's, right? This gut-brain immune activation, driving Hashimoto's, autoantibodies against the thyroid. And then it's also what drives all these other things too. These are those chronic illnesses I'm talking about. These are some of the branches of the tree, and they're driving all these different other things that people can experience. The root of it in most cases is some degree of gut-brain immune imbalance. Along with this, there can be hormonal imbalances, whether it's thyroid or sex hormones or adrenal hormones. There can be toxicities. There's a lot of factors here. The brain part, obviously, this is where the whole chronic stress, trauma piece comes in. So this is just a funky little cartoon that's showing us right down here. We've got like T4 going to T3 and reverse T3. And what it's just showing us that both inflammation and significant stress, this is a very aggravated looking person who's biting a pencil. And these are some of the biochemical pathways, hormonal pathways and cytokines like TNF that we talked about, tumor necrosis factor, that do a whole cascade of things that reduce conversion to T3 and increase conversion to reverse T3. So whether it's stress or inflammation or both, and they often go together. Another little ditty about stress hormones themselves, and this is just a clearer picture about how cortisol, which is one of your chronic stress hormones that can get very out of whack, especially if you have, the four main things that can affect it are profound, like early life stress trauma, recent life stress trauma, blood sugar instability, lack of sleep, like when a person doesn't sleep well, has an alteration in their bodily clock, their cortisol can get out of whack. And the last thing is inflammation. So there's a vicious cycle between cortisol and inflammation. It drives it up. Chronic stress and inflammation increase cortisol levels. Increased cortisol can suppress the pituitary, so you got less TSH coming out, and it can also suppress the actual conversion. We talked about this deiodination, where the T4 is supposed to go to T3, but instead you get reverse T3. And we already kind of talked about gut health. This is just a cartoon that's showing the whole leaky gut dysbiosis thing, where here we are inside your gut, and you got this special barrier that's broken down, and your body's absorbing into the bloodstream all these little proteins and sometimes bacteria and bacterial proteins that really create havoc and create all sorts of immune reactions and feed into things like food intolerance, blood-brain barrier breach, systemic inflammation, nutrient absorption. Like thousands of years ago, both the Greek and ancient Hebrew philosophers said all disease starts in the gut. And now here we are in 2020, 2022, and we're also figuring that out. Oh yeah, diseases start in the gut. So see, these are some of the medications, Beta, listen up, sorry, that block conversion of T4 to T3. Beta blockers often get used for high blood pressure, sometimes for anxiety, birth control pills, estrogen replacement, lithium, anti-seizure medications, theophylline used in asthma and lung disease, some chemotherapy. Mrs. Leshen's asked, oh, sorry, someone's asking privately, what's euthyrox? Euthyrox is thyroxine. It's T4. It's used to replace thyroid hormone, but it's just T4. It's not T4 and T3. The thing that I didn't get back to, we'll get to it, sorry. So this is just a couple of pieces of research where it looked at supplementing people with zinc insufficiency and showing improvement in thyroid hormone levels and also sense of well-being. So increasing the serum free T3 and reducing reverse T3 by supplementing zinc. He's got a little out of order, but in any event, so integrative treatment, what do we do? After diagnosing it, after doing a really clear history, looking at the roots, the trunk, the branches of that tree, we want to reduce inflammation, frequently starting with the gut. We want to deal with stress and stress hormones. And there's a lot of different ways to do that. We want to supply the nutrients, and I'll talk a bit more about thyroid-specific nutrients, but there's other nutrients that can be beneficial in terms of inflammation and stress and all that too. And we want to, and exercise enhances thyroid hormone effectiveness. So when a person can do it, gradually building exercise can actually enhance the function of thyroid hormones. Gradual increased exercise reduces inflammation. It also balances stress hormones. It also creates happy hormones. So I'm a big fan of lifestyle. And that's exercise, it's mind-body therapies, it's diet, it's time in nature, spirituality, self-care in a really deep way, creating a sense of like, okay, it's safe for me to be me. That's what mind-body healing is about. You know, so much comes from that root. That's another piece of deep spiritual wisdom that the sages and the philosophers talked about, that so much of our chronic illness is coming from angst and grief and sadness and a sense of disconnection, and the way that propagates through all of our physiology. And on the other hand, joy is a healer. When we intentionally generate joy and we actually bring it into our heart and body and we live from a joyous place, it is a disease preventer and a disease treater. And it doesn't mean everything's in your head. What it means is that your head and your heart are a means of helping your body and mind heal. The last thing I want to mention here is that a more nuanced thyroid replacement, right? So most docs are fixated on T4, and that's why thyroxine is, or euthyrox. Anything that says thyrox almost always is T4. And like we talked about, if you've got various things that are affecting conversion of T4 to T3, then just getting more T4 is not going to necessarily help. And that's part of the reason people go up and up and up on their doses of T4, but they're still symptomatic. And so the idea is getting at these underlying things and shifting the biology that's affecting the lack of conversion or the misconversion of T3 to reverse T3, and also the other things that can enhance sensitivity of the cells. And so there are products that are just T3. So sometimes we'll just add T3 to the T4. You can compound where you get a capsule of T4 and T3. It's a little more expensive. And then there's actually like natural desiccated thyroid hormones. There's a lot of different, depending on where you live. I just want to show yeah. So for instance, I'm going to share a different picture. You know, this is just one of my little guides that I have, right? And these are different alternative thyroid substances. There's something called armor thyroid, and that's desiccated thyroid. And then there's Synthroid, Levoxyl, Luthyrox, that's synthetic T4. And then there's Cytomel, which is just T3, and a couple other ones that I don't use so much. So in any event, there's different ways to supplement thyroid hormone. I just have another couple of slides and then we'll go. And, you know, this is my overall framework. And I encourage you to just sort of reflect on this in your own journey, because in my experience, all of these are equally important, and I'll explain what they are. But what I see a lot of times, people come into my office and they're really addressing one of them really well, but they're missing the other ones. And so I call it 3 M's: mind, movement, and metabolism. And the whole idea is that, you know, we're talking metabolism, inflammation, thyroid hormone synthesis and breakdown, other hormonal things, all these different things that are going on that are sort of like the biochemistry of the body. And you really need to think about that. But then all those mind-body relationships are incredibly important. I think there's oh yeah, explain it here, whatever. You know, the mind part is just your thoughts, your emotions, your awareness, and it can be healing or the opposite. And so a lot of people come to me with, they've spent thousands of dollars on their metabolism, but they're walking around with so much stress and angst and frustration, and they can be living with a tremendous amount of embodied fear because of early life trauma, or because of the deep physiologic stress that comes from inflammation. Inflammation's a stressor. And we have to realize that stress isn't just about your mind. Like, I know a lot of people who, because of their spiritual religious beliefs, are living in a place where their head's okay. They've got a good outlook, they're positive, they're doing their daily prayer or their scripture or their divine service in whatever way that gives them meaning and purpose. So they're doing great between their ears, but they're fidgety. Their skin, they got these things going on that are like, no, this person is not calm in their body. And that's reflected in what we know about the physiology of the mind-body system and the vagus nerve, that you've got evolutionary levels of the vagus nerve. You've got these different aspects, some that are controlling the face that we put on for ourselves in the world, and then some that are controlling like what's going on in your body, in your felt sense of living. And so my sense is that all the mind stuff and the psychotherapy and the spirituality that's intellectual, mental, expansive needs to be brought into the body, which is why I do that kind of work with people. It's really sitting down, counseling, and training around bringing calm, clear, aware, non-judgmental consciousness into the body and actually encouraging the body to come along with the calm. And that's actually anti-inflammatory. It changes physiology, and it's quite profound. And then movement, your structural movement system of your body. Our bodies were meant to move, and we live in a world and society where most of us are sedentary. We're not exercising, we're not walking, we're not farming, we're not, spending time in nature. And so movement and exercise has a profound impact on so many different aspects of your biology, calm your mind, reduce inflammation, enhance the tone of your vagus nerve, enhance your thyroid function. Inside your cells, you've got organs called, this is really important for people with fatigue, right? Inside our cells, we have organs that are called mitochondria. Mitochondria produce cellular energy. They're very connected with thyroid hormones and stress hormones. But when you exercise, you actually enhance mitochondrial function. Unless you go over your threshold, you have to be careful with that. If you've got profound fatigue or chronic fatigue or fibro, if you do too much exercise, you can create a stress state that hurts your mitochondria. But we all have a threshold. When you go close to your threshold, you push your system a little bit, and it actually makes your mitochondria healthier, and then you have more energy. So a lot of people report that. I've got so many people that have come to me and said, oh yeah, when I started exercising, I got 40% better. What if you felt 40% better? That often opens up enough energy to do more self-care, to do the stuff around metabolism or mind. So you really got to address all three of these areas. Just a little representative research about gluten-free diet and thyroid disease. So this wasn't a big study, but like normalizing TSH values and normalizing the way people felt, they just felt better. And then the ones who didn't feel better, it's because they weren't complying with the diet. These are some of the key nutrients. We've talked about them already in that little diagram of thyroid hormone conversion: selenium, zinc, iron, iodine, vitamin D, vitamin A. Crucially important. Here's that diagram again, right? Here's your vitamin A and zinc. Here's your zinc and selenium, your B vitamins, C and D. That slide didn't mention vitamin E, but it's in there. Selenium and zinc converting T4 to T3. There's been a number of studies that I've seen looking at people with Hashimoto's who are given selenium with decreased in their antibodies and improvement in their other thyroid hormones values and feeling better. Really important thing to consider. It's just sort of a warning note. There are thyroid supplements out there that are just, like thyroid. I don't have the names of these things, but I see them. I look at various websites. It's like some random companies making thyroid support. And you look in the back and it's got thyroxine or T3 or something like that. You really need to be careful of this stuff, because this was a test that was reported a number of years ago. They looked at 10 popular thyroid supplements. 5 of them had T3 at greater than 10 micrograms a day. I treat people with T3, and that's how much they get a day. Sometimes 10 mic. So in other words, that person could be being treated with other thyroid medications, and they go and they take this supplement and they get twice as much T3, and suddenly they could be hyperthyroid. So you just have to be careful. Okay, a little bit about food. Some of this is controversial, right? Like soy, if there's too much of it, can reduce your absorption of thyroid hormone. And so it also can affect iodine uptake. You need to make sure you have an adequate iodine level. And if you're going to eat soy, you should wait, and you're taking thyroid medication, you should wait a few hours. There's a lot of controversy about what they call goitrogenic foods, right? Like leafy greens that are cruciferous, like broccoli, cauliflower, cabbage, kale, spinach. There's a lot about this in the popular press, like don't eat too much kale or spinach or Brussels sprouts because it could screw up your thyroid. I traced this down one time, and from what I can see, it was all taken back to a few cases of people who were reported in the medical literature who were having like this much kale a day raw in a smoothie. They were just pounding the kale smoothies. They really overdid it. And it can affect your thyroid if you eat, a pound or something or two a day of kale and broccoli. Like, don't eat that much. Have a few servings. I mean, some say ideally cooked or steamed. I would say that those things are really good raw too. And when they're raw, they actually produce a lot of chemicals that are really involved in detoxing inflammation and oxidative stress. Sulforaphane is incredibly important. So gluten, we talked about that a bit. Celiac antibodies are associated with Hashimoto's, but there's much more to it than just celiac antibodies because it can be inflammatory in general in the gut and systemically. Caffeine can inhibit absorption of thyroid hormone. So again, you should wait if you're taking thyroid hormone. And alcohol is just a big thyroid boo-boo. Like if you have hypothyroidism, be very low on the alcohol, be gentle. It's a toxin, alcohol. I mean, I enjoy a little bit of alcohol. It's nice. But if I were chronically ill, I think I'd just get rid of it because it is a toxin to the body. And then foods that support thyroid function. Yeah, healthy meat and fish that has omega-3 fatty acids from wild-caught fish and like free-range beef, grass-fed beef has omega-3s, zinc, iodine. Moderate amounts of seaweed are actually producing iodine. I live in a country that is coastal. We eat a lot of fish, but they don't iodinize the water here. And a lot of the salt doesn't have iodine. Himalayan salt. I love pink salt. It's full of nutrients, right? There's no iodine in there. So you really should be careful, especially if you live in a country where there's a lot of endemic hypothyroidism. I mean, low iodine, which is true of where I live right now. So eggs have good amounts of iodine and selenium, and probiotics and prebiotics in general are pretty good and healthy unless you're immune suppressed. It's good to get some guidance on this. There's a lot of probiotics that are just junk and some that are high quality. I want to emphasize how important is prebiotic fiber because the prebiotic fiber is what helps your probiotics grow. We're talking ecology. We're not talking about medications. We're talking about putting in a bunch of organisms and giving them the food they need to thrive. And that balances the inflammatory picture in your gut health. When you have balanced flora that are well fed with prebiotics, it creates chemicals that feed your brain in a very positive way. If, on the other hand, in contrast, if your biome is really out of whack, it's toxic to your brain. Okay, so enough slides. Here's just a little information. These are the kind of people I see. I've enjoyed talking with you. I'm going to stop slide sharing and let's just talk a little bit if people have questions. Sandy's asking, how much selenium? Do some vitamins have some selenium in them? Right. So great question. Right. And Bayla's bringing up a great question too, which is that hormone replacement therapy. Hormone replacement therapy can be very useful for people who have perimenopausal symptoms that contribute to lack of sleep and other things. And should it be avoided because it affects the T3? And I think it needs to be very individualized. And I think it depends on what hormone replacement therapy you're taking. I'm not a big women's hormone therapy guy. So I'm not the one to say, well, which one should I take? But what I know is that some formulations of hormones aren't tolerated as well by the body, and they contribute to an estrogen progesterone balance that isn't so favorable. And so it's really individualized. And I suggest that people actually get professional guidance for that, whether it be from a naturopath or a functional doc. The question about how much selenium and the fact that some vitamins have it, they have it, but the question is it absorbable? The thing about vitamins and supplements in general is that, first of all, there's three main categories of things that can make supplements not work very well. One is that they're made without good quality control, and it doesn't even have what the label says it has. And that's been shown over and over with so many different supplement brands. So it's really good to get some kind of third-party assurance. And some supplements have third-party testing stamped on their bottle that says, okay, this has what it says it had, and that it's made through good manufacturing practices, GMP. So what is GMP? GMP means this supplement wasn't produced in some field where they were pouring toxic chemicals, or, you know, it's not made in a plant where they're also making batteries or something like that, where there's cadmium everywhere. So like, you want to have good manufacturing practices. You want to have accuracy in labeling. And the third thing is absorbability. Because if you're making an inexpensive supplement and you're manufacturing it in a way that you can have a machine that processes like 1,000,000 pills an hour, you're going to bind it and put stuff in it that makes it easy to manufacture and doesn't necessarily make it easy to absorb. And so you might be taking a vitamin that's got a little bit of selenium in it, but you might not be absorbing it because it might not be breaking down in your gut. So especially if you've got like gut issues. So my sense is that if somebody is dealing with Hashimoto's or thyroid disease and wants to take supplements that are thyroid oriented, that you should focus and get like a more focused either thyroid hormone thing from a reputable company where it's like a powder inside and not just packed with magnesium stearate, or actually taking selenium alone, so you're more likely to absorb it. So Bela is writing salt that's got extra iodine in case you want more iodine, but you can just use Himalayan salt. Bela, I respectfully disagree because I suspect there's different brands, but I recently looked at the Himalayan salt in the like natural food store where I live. I looked at 3 different brands. None of them have iodine. So I would look for, oh, I see. Okay. Answering Michele, fine. All right. I think I got all of the questions. Right. People recommend Himalayan salt, but the issue is the iodine. I think you got that by now. Are there any more questions? You know, we can go gallery view. If people have questions and you want to raise your hand, we could do this verbally if you want to actually speak up. So feel free if you got a question. And if you don't, we could adjourn. Is iodine supplementation good? All right, Shyam's asking a great question. So here's what I want to say about iodine. Theoretically, if you have active inflammation of your thyroid, iodine can actually worsen that. So you want to be careful to make sure you don't have active Hashimoto's. And if you do, going very low on the iodine. And yeah, so you have to be careful. And my view is getting it from food is a better way to get it. I actually eat seaweed at least once a week to get enough iodine. And you can get seaweed in bags and it's tasty and you can prepare it in different ways. And I find it delicious. So that's how I go about it. Some people, you know, there are thyroid supplements that have a bit of iodine and it typically has like 50 or 100 micrograms. Some have 150 micrograms. Shyam's also asking, how do we rule out Hashimoto's disease? Great question. Really, it's by testing for the antibodies. And there's something called a TPO antibody and a TG antibody. Those are the things that go up in Hashimoto's. And again, those are things that the average doc isn't necessarily testing if no one's pressing them to do it. But if a specialist is saying, hey, you should test these, or the specialist does it, then that's how you get those things tested. And that's how it works in my practice. I work outside the system in the country where I live. In the States, when I do telemedicine, I order labs through Quest or whatever it is, Quest usually. And so I can just order those things like a TPO antibody and a thyroglobulin antibody. Other food items for iodine. Jackie, that's a great question. I don't have an answer for you. I'm sure there's something. I think shellfish and fish in general are the ways to get iodine because there's a lot of it in the sea. I don't know what else besides that. Bela has another question. You want to unmute? You're in the dark, but you look kind of mysterious.
Yeah, sorry, let me put up some lights.
No, it's okay. We can hear your voice. Let's not distract from the. You're welcome, Shyam.
Yeah, let me reframe the question because my mind goes from I to Z, etc. Gee, it's because there's like so much info tumbling in my head, and I was like, hold the question. Right. Oh yeah, what is exactly the test that can tell which your reverse T3 is too high in your in the absorption or resorb, I don't know how to call that, in the body, the
So,
response of the cells, even
yeah,
though the pituitary gland says, okay, there's enough,
right,
but it
right.
happens not to be so.
I hear what you're saying. So, you mentioned reverse T3, but I think what you were saying
Yeah, the
was,
amount of the ones that are not capable by being used by the bodily tissues.
right. Yeah, let me see if I understand your question. I think what you're asking is, how do you know if your cells are actually responding to the T3 or not?
Yeah.
If there's enough of it, and if your cells are responding and are sensitive.
Mhm.
And I don't think we have a way of directly measuring that. We might, there might be researchers in some specialized laboratory somewhere that can somehow do that in a petri dish or something like that. But it's really a clinical diagnosis, right? It's like looking at the whole picture, like in the old days, we had newspapers that people would pick up and read. And I'm not sure if any of you have actually been to a place where they're printing a picture in a newspaper and this thing comes out and it's just going dots, dots, dots. It's making all these dots. And before you knew it, there's a picture of a bridge that appears from the dots. And that's part of the art of medicine, is looking at the dots, and the dots are the history and the physical exam and all the labs together.
But
And
what
that's how
is
we
the
come up with a clinical diagnosis. And so, like,
Mhm.
because we don't have a great way of measuring that, there is an aspect of it that's clinical, right? So we can look at the free T3 and the reverse T3, and we can look at the ratio of those things. And if the reverse T3 isn't elevated, then that's a good sign that your body's not producing too much reverse T3. And so that's good starters. But you're right that even with that, like in that one slide that I read, some people still have a decreased T3 in the cells, or decreased sensitivity of T3. And that's really a clinical thing. That's
There's
related
no
to
way to
symptoms.
measure that.
And that's
Not
symptoms,
exactly.
it's looking at a whole
Okay, it's the
constellation of
symptom.
symptoms. I check the reflexes on the person, it's a clinical diagnosis.
So in case I want to go to my doctor, I get this test done and the results are all okay, then how do I know if I do have certain symptoms that might um, lead to a diagnosis of a malfunctioning thyroid?
Right, right,
How
um,
do I find out
right,
if the doctor's tests that I regularly get, like with the TH3 and the TH4, are not showing it?
right.
But the complaints, like for fibromyalgia, just in my personal case,
Yeah,
are very similar to the hypo or the hyper or the hypothyroid.
right, right.
So
So,
how to find out
yeah,
whether your fibromyalgia is not being caused by a dysfunctional thyroid?
yeah, it's a really great question. And I think part of it is, the best thing is finding a clinician who really thinks about these things, who studied these things, who can see you, and you can go and meet that person and they can really examine you and think it through, and test all of those tests, first of all, because those also give clues. Um, and for sure, there's a possible situation where, you know what, your reverse T3 is normal, and your T3 is normal, and your T4 is normal, and your TSH is normal, but you still feel crummy. Do you have hypothyroidism? You know, when all those things are getting normal, it's getting less and less likely. Ayelet, thank you for being here. Thanks for, I hope it was good for you. So as more and more things are normal, the likelihood of having something going on is less. But for sure, there is probably a very small subset of people who, with all those tests normal, even the more sensitive ones that I mentioned, could have an impaired sensitivity to T3. And so you're welcome, Maria. Thanks for being here. So what I would suggest is trying to see someone who can think it through with you and think about those symptoms, and think if there's other reasons that they could be causing those symptoms. Think about all the tests. If someone can examine you, that's good too. And the other thing is and some people would just empirically treat with thyroid hormone. And there's a lot of docs who do that, who will do a trial of thyroid hormone, and typically a combined thyroid hormone like a T4, T3 combination. So that's also a reasonable thing to do. Did you
Can
hear
it
what
harm to do that on a certain amount of time?
Well, what you need to do is you need to watch the TSH, and you need to just see what's happening with the system overall. And for sure, that's one of the arguments that conventional endocrinologists make against the whole world of kind of a more functional approach to hypothyroidism. The concern on the other side of treating with T3 is it going to cause a person to have tachycardia? Is it going to cause a person anxiety? Is it going to cause osteoporosis?
Mm-hmm, mm-hmm.
And it's a real risk to consider for sure.
Yeah, that's what I was thinking.
Each individual has to be an individual case, because it's kind of like, all right, so here this person's suffering, they're exhausted, they've got brain fog, they can't function, they got widespread pain. If we've done all of the things to eliminate inflammation, if we've healed the gut, if we've provided nutrients that could be expected to enhance thyroid function, and they're still not getting better, and then the decision risk benefit is like, okay, if we do a trial of thyroid medication, they might feel a lot better now and have a much better life and be much more productive, and all the different things that go along with living a meaningful life because you don't feel like a rag. And the risky side is, okay, well, what if we're overstimulating the thyroid? Could there be something that happens down the line? There could be, and everything's a risk benefit and needs to be very individualized.
Mm-hmm.
And so, you know, the unfortunate reality is that often means, well, you need to find someone who can think it through in a careful way, who is a compassionate person who's going to have your best interests in mind. And who isn't
What
just
would
going
you
to be trying to,
recommend? Like, I don't know what it's like in many other countries, but in my country, there's really a separation between regular medicine and what we call supplementary medicine. I don't know why we call it that way, but it's just really literally translated from my language. So the idea of integrative medicine is not really very much happening in this part of on the globe that much. There are certain doctors that do that, but a lot of these people, they are just only specialized, let's say, in orthomolecular healing by providing the idea of taking extra supplements, etc., etc. But they don't know a thing about medicine.
I understand what you're saying.
And
so what you're saying is that
creates
in the world
friction.
of supplementary medicine, you get people who are not necessarily studying deeply into these other things to figure out how to fix them, but they're just like, oh, you've got these symptoms, take these supplements, right?
Mm-hmm, mm-hmm.
I hear. I mean, I think the answer is you have to search carefully before you invest your time and resources in seeing a private doctor who does supplementary stuff.
Yeah, because at the beginning, I went to one of those persons because in the beginning, I mean, when I just got diagnosed, because I didn't know where to start. And he gave me a prescription. And then when I looked it up later, I found out it had a lot of danger in damaging the liver. It had a lot of hepatotoxicity.
Right.
And I was like, how on earth can I pay so much money to such an idiot who is telling me, because they are also selling a lot of them have a wholesale retailer, whatever, with the supplements they sell. So that's a lot of money wise. They are interested in having to sell their supplements because they make extra money with it, and they're not doctors.
So I can't fix the system, right?
I know.
All I can say is that I know that in most places there are individuals who are ethical, who are compassionate, who are actually trying to have the patient's needs first, who are thinking these things through. And it can be challenging to find that person for sure. But I encourage you to try.
So our best bet in this situation would be to find a well-educated medical person who is open to exploring their horizon. That's
and I mean, you're in Holland, if I understand correctly, and like the EU, there's a lot in Europe. There's a lot of docs like that in in Denmark, in England. I mean,
Yeah, there is, but a lot of them are not being paid for by the health insurance.
right. I
And
hear.
that is a problem when you're being chronically ill and you
I
cannot
know.
make a fortune to live
Yeah.
off.
It's hard. I hope you find a solution. I really do. I really do. Okay, I think we need to wrap up here. Racheli has a question. You've been looking so intently and thinking a lot, I can see.
No. I have a question, but I might write to you. I'll ask it. I just was wondering in follow-up of Bailey's, do you think it's good at least to still stay in the system and seek external assistance? Because is there a big disadvantage or advantage to staying in the system and doing both?
I think it depends where you are.
Yeah.
Yeah, I think where you are, you should stay in the system too, because that's where you get basic stuff done.
Okay.
And that's where, if you actually need medications, if you need standard labs to be followed, that's where you get that stuff done. And there are a few specialists that in that country that are open-minded, integrative people who can help you work the system. And that's kind of part of it. So.
Okay, thanks. And I was also wondering if you're going to send a link. That's all.
A link to what?
To the recording.
Oh, yeah, that's a good idea. I think everyone who
Thank you.
registered will get a link to record the recording.
Okay.
And I'll probably post it somewhere. And it's a long recording. We've been at this for an hour and a half. I have a problem. I talk too much. In any event, thank you all for being here.
Thank you very much.
Quick just response to BV. What if you have rising antibodies while your TSH, T4, T3, and RT3 are still normal? Can they go back down? Or is it mainly about trying to keep them from rising? No, I think if your antibodies are rising, you need to be thinking about, well, what's driving that? Was your antibodies to what's driving that? And the whole picture that I shared in terms of like inflammation, infections, stress, nutrients, all those things are involved in the generation of autoimmunity and overactive immune system. And that's a more root thing, right? The root is the inflammation. And then there's the roots of inflammation. It's like you can keep going back into like what's really the root of all of it. Okay, my friends, thank you for being here. And I'm going to sign off. And I wish you all I guess we're all here because we're dealing with various challenges. And, I wish you success in finding solutions to all of that, whatever it is that you're dealing with. So thank you for showing up.
Thank you, Dr. Shiller.
Okay, bye, everybody.
Thanks. Have a good night.
You too. Bye-bye, Sandy.